Hi, I'm reviewing a retrospective case series on opioid agonist titration in pregnancy that I did with the addiction medicine group at St. Mike's. The precedent for this project was a case study of rapid methadone titration in a non-pregnant patient. Methadone has been around for a long time, but there is still a lot of concern around its use and the potential dangers, given that the bioaccumulation in a long half-life leads to conservative dosing guidelines. The guidelines for titration of methadone from the CPSO and then endorsed by the ACOG as well as SOGC endorse a very conservative dosing strategy. Most addiction medicine specialists think that this schedule is inadequate, especially in light of the fentanyl era, because patients who regularly use fentanyl have a very high opioid tolerance. Especially later in pregnancy, there are also changes to methadone metabolism, and it is a higher methadone clearance, which leads to higher dose requirements as pregnancy progresses. I'm going to be describing cases where pregnant patients with opioid use disorder were rapidly stabilized on methadone with adjunctive slow-release oral morphine called Cadian. We were able to make a protocol based on our case series. Methadone and Suboxone are the current standard of care in pregnancy, but slow-release oral morphine is also safe. In general, higher OAT doses are more therapeutic and reduce opioid and non-opioid drug use in pregnancy. Our chart review is from January 2016 to August 2020 and includes adult women of any gestational age who are starting or restarting OAT with methadone and/or Cadian. Our main inclusion and exclusion criteria are listed under the methods. We included 12 patients who were about 30 years old, many unhoused and of low income. Many had hepatitis C, with none completing prior treatment, and one was newly diagnosed during pregnancy. All were using fentanyl, and many were using stimulants as well. Little under half had been on OAT previously. None of the women were admitted in the first trimester, and just to keep in mind what I mentioned about dosing and pharmacology later in pregnancy. The dose of methadone started on 30 milligrams, which is the general starting dose in most patients. We were able to increase to 70 milligrams generally within a week. You can refer to Table 2 for more dosing information, as well as Figure 1 for our proposed protocol. We can achieve much higher doses much more quickly. Consider the morphine equivalence, with the total daily morphine equivalence being over 1,000 milligrams a day in patients who are on both methadone and Cadian, which also speaks to the high tolerance. Also notable is that there were no documented adverse events and no self-discharges. However, even with stabilization, many did not maintain their OAT. Of course, the overall limitations of this type of study apply. However, we do show that this may be a safe protocol in a monitored setting for patients who are using fentanyl, aided in part due to the metabolic changes that occur in pregnancy. It is important to highlight this is a fairly unstable population, and pregnancy is an important time for engagement in care when motivation tends to be high. We may be able to capitalize on that by aggressively treating opioid use disorder. Of course, this is done off-label with addiction medicine specialists. Please also refer to the considerations and next steps, but overall, we need to better understand factors associated with treatment engagement and retention, especially in the fentanyl era. And also, we should be challenging some of the dogmas of methadone maintenance therapy. Thank you very much for your time.